If you wouldn't mind,
I'm sorry, can you say that one more time?
if you wouldn't mind presenting the slide, I'd appreciate it.
Yeah, no worries.
And I apologize for the glare as well. It is fortunately a really sunny, lovely morning in Harrisburg, Pennsylvania. So you'll have to forgive me for that. But I'm excited because a bunch of my favorite people to work with are on this call. So it's really good to talk to everybody. I hope that we can just make this more of a conversation. And for those of you who don't know quite as much about the Pennsylvania Rural Health Model and why COPD is so important, my goal today is to really share a few thoughts with you around that, and at a high level share with you what a lot of the hospitals are doing around COPD. So this is actually a presentation I put together. Grace Ann was generous enough to ask me to serve on a panel with her in DC back in maybe February. And so this is a presentation I used on that panel. And I'm really excited to share that 6 months later, we do have some exciting updates. So I will kind of build that into the voice track today. So if you have any questions, feel free to just jump right in. But otherwise, Caitlin, if you wouldn't mind advancing the slide, please. I think if you just pop it in presentation, yeah, perfect. There we go. Okay. So the Pennsylvania Rural Health Model really came about because a lot of rural hospitals in Pennsylvania were struggling to remain open under a fee-for-service system like they are kind of across the country. And while, I don't think the struggle is unique in Pennsylvania, I do think that we have a unique opportunity to test a different way to pay for healthcare in order to prevent rural hospitals from closing and ensuring access to high quality care in those communities, as well as jobs. And I would say from a Commonwealth perspective, the job and economic vitality aspect of this is so important. For most of our rural counties in Pennsylvania, the hospital is the largest employer. So this is a huge economic issue for the Commonwealth, and one that we are very humbled and excited to hopefully help to get to be a part of the solution. Next, please. So the model really came about a few years ago, but it functionally went live January 1st, 2019. And when I say that, I mean hospitals started receiving payment differently than in a fee-for-service system, and they started implementing something that we call a transformation plan that we'll talk about in a little bit. So the Pennsylvania Rural Health Model is administered by the Pennsylvania Department of Health in partnership with the Center for Medicare and Medicaid Innovation, CMMI. And so many of you know this, CMMI was charged with the task or opportunity to test alternative payment models at a state level with the passage of the Affordable Care Act. And the Pennsylvania model is one of those. It is one of 3 all-payer global budget models that is being tested across the nation, but ours is the only one focused specifically on rural. And I think that's important because the methodology that we use to calculate payments and to pay hospitals is different. And so one of the primary goals of the methodology is to stabilize the payments that hospitals receive in order to make them more consistent so that there isn't the volatility that hospitals experience under the fee-for-service system. And we want to change the incentive structure around. And so now, instead of being paid for driving volume to the hospital is paid based on providing the services that are appropriate for its community and improving population health, access, and quality. And so that's at a high level, a little bit about the model. But I think what is exciting about it is that we have an opportunity to test whether hospitals will be able to thrive under a different type of payment model where we have realigned the incentives, where we are focused on population health. And our goal is really to keep people out of the hospital. We call that potentially avoidable utilization, PAU. And that's actually a big part of why we ended up focusing so much on COPD within the model. Next clip, please. So I mentioned before that there's sort of these two pillars to the model. There's hospitals are going to get paid differently, and hospitals are going to implement this thing called a transformation plan. And so within the transformation plan, there are all different types of things that hospitals wanted to do. So the first year of the model, that is the hospitals that are currently in the model, there are 5 of them. And there were some clear winners in terms of what most hospitals wanted to focus on. And that really revolved around standardizing care pathways and clinical protocols, more effectively identifying patients who are high need, high cost, deploying care management to those patients, and wanting to start doing things, I would say, around social determinants of health. So that's kind of the transformation plan for the first year of the hospitals. You know, it was pretty broad in the sense that they could kind of pick and choose whatever they wanted. So it was interesting that most of them landed on kind of similar topics. That made my job a little bit easier because I'm responsible for working with all of the hospitals to develop and implement their transformation plan, as well as bring resources to support that implementation. So it's not my job to tell the hospital what to do, but once the hospital puts it in the plan, it is my job to try and help them make that vision, you know, come alive. What's interesting, we are, you know, a little bit more than halfway into this first year. And I went and visited with all of the year 1 hospitals about 3 weeks ago, I guess. And they are almost at 100% execution for their transformation plan. 4 out of the 5 have 100% execution. 1 is just a couple of weeks behind on a few things. But we're very excited to see these coming alive. And really the goal of the transformation plan in the first couple of years is to reduce that potentially avoidable utilization. And so based on the financial and clinical modeling that we do for hospitals upon entrance into the model, as well as what their China says and what, you know, they as clinicians and hospital leaders know, is that COPD is, for the first year of the hospitals, the #1 disease state that is driving potentially avoidable readmissions. And so that's really how we landed on, while the transformation plan itself can be pretty broad, it so happened that there was this really key area on which all of the hospitals wanted and needed to focus, and that was COPD. Next one. So there's kind of a continuum, I would say, of things that hospitals are doing around COPD in order to improve patient outcomes. And what we are predominantly after is reducing readmissions as well as inappropriate ED utilization. It's those 2 things that drive what we define as potentially avoidable utilization. So we're basically looking to reduce the readmissions, and we're looking to keep people out of the ED unnecessarily, whether that's, you know, getting them into primary care or whatever that most appropriate point of care is. I think, as you know, anybody who works in healthcare, we obviously want exceptional patient outcomes as well. And I think you'll see that kind of comes in here. If you could click, Caitlin. So the first thing hospitals are really focused on is patient identification. A lot of that more came into using the EHR effectively in order to identify and then track those patients who had COPD. And I recognize that that may not sound super hard, but some of the EHRs that we're working with are not the most cooperative, I'll say. And so this piece is actually very important, because you can't manage a patient population and you can't treat them if you don't know who they are. And so we have a group called Quality Insights that is actually coming in and working with the hospitals in order to make sure that they are using their EHR effectively so that they can identify those patients and track them over the course of their treatment. Next. And I think there might be one more that goes with this, Caitlin. Oh, that's okay, you can just leave it. So another big piece of that is once the patient has been identified, ensuring that they've been diagnosed through spirometry. So this is something that I know a lot of folks who attend these calls are very, very passionate about. And so something that one hospital is doing is literally for every patient that they see with a primary diagnosis of COPD is calling the primary care provider to say, okay, did you diagnose this patient, or how did we get this diagnosis, to ensure that the patient has been diagnosed through spirometry. And we have one hospital in the first cohort who is buying a spirometer. So they're going to start to do the diagnosis themselves through spirometry. So I think that's something, you know, the year one hospitals within the model have been coming to these sessions, at least that's my understanding, fairly regularly, and they speak really highly of them. And this is a piece that I think has not been lost on them, and they've really taken away from APHP. Smoking cessation is obviously a huge component of what we need to be doing, you know, in terms of the spectrum. Pennsylvania has a lot of really cool resources related to smoking cessation. We have something called the Quit Line, which maybe other states have as well. But basically, it is an opportunity for a patient who's trying to quit smoking to have one-on-one counseling with a certified smoking cessation counselor. And should the patient continue to go to those counseling classes, they can go to up to 5. Except if they're pregnant, then they can go to 8. I think that's what it is. They are able to receive nicotine patches, gum. I think those are the 2 that are offered, and free to them, and that will be mailed to their house. The ALA also does a lot of great work, obviously in Pennsylvania, but something that I'm working with the Department of Health to do is to kind of create a third smoking cessation option that's between the Quit Line and like the ALA Freedom to Quit program. And we're looking to create almost like a conference call line that would be a smoking cessation program. So we would have a certified counselor lead the discussion, but patients from all participant hospitals would be welcome to join so that they would get more of that cohort-based experience that you get in a class. But obviously in rural, you're going to have often a driving distance that may not be reasonable or doable for somebody on a weekly basis. And so instead, we're going to do these conference calls so that people can do them from the comfort of their home. And we'll do it, you know, every Tuesday night at 7 or a Thursday at noon. We're still kind of working through those details. But this is something that, you know, we feel like we're trying to meet patients where they're at and come up with some rural specific program designs, which, you know, I think the state is very supportive of. And so this is something that we're looking to roll out early in calendar year 2020. So I would be interested if anybody else has ever tried a program like that, and if it went well or didn't go well, we're just going to kind of try to pilot it here, but I would be interested in anyone else's lessons learned or thoughts there. Next one, Caitlin. And then there's 2 here. This is the one that's flipped. Yeah, perfect. So pulmonary rehabilitation is obviously a huge, a very important thing to do from a clinical perspective for patients with COPD. Once they've been properly diagnosed, you know, you're trying to get them into smoking cessation class. And we know that this is a topic near and dear to a lot of people's hearts on this call. I'm really excited about this because a number of the year 1 hospitals actually stopped doing pulmonary rehabilitation because the reimbursement was so poor, but now they are bringing it back. So I would be remiss if I did not thank Chafee, because Chafee actually was kind enough to come to Pennsylvania and do a training with the year 1 hospitals on how to stand up pulmonary rehabilitation. And when I was visiting with the hospitals a few weeks ago, most of them hearkened back to that when they were describing to me the progress that they've made. So I'm very excited because all of the year 1 hospitals one of them had pulmonary rehabilitation to start, but the other 4 did not. And 3 of the 4 are now standing up pulmonary rehabilitation again. And it's not always, the most glamorous or beautiful, way to do it. Some of them just have a treadmill or a bike or an ergometer, and they're kind of putting it in a room, and they've got a respiratory therapist, they've got a supervising clinician, and they're just kind of starting small to see what the demand signal looks like, and then they're going to build from there. But this is an area that the hospitals are really excited about because they feel like it's a clinical best practice that they now get to offer at their facility for their patients. And I know that they're very proud of that. From a I'm sorry, Caitlin, can you click one more? Yeah, okay. So in addition to the pulmonary rehabilitation, one of the hospitals this year, I think there will be more in the second year of the model, are considering doing remote patient monitoring. And so when I talk about remote patient monitoring, I mean, like there's an SpO2 device in a patient's home that has a transmitting hub, which can either be, a person's cell phone if you get good enough cell coverage out there, or just something in a landline that transmits that data to a central hub that is monitoring a patient's vitals and progress. And should a patient fall outside of a normal parameter, then that is escalated through a protocol that's defined by the patient's primary care physician, the hospital, and the patient. And so this is an area that I think is really promising for hospitals participating in the model, but also patients, because remote patient monitoring for COPD patients is shown to clinically improve outcomes. And so I'm excited about this opportunity. Only one of the hospitals is doing it in the first year. I'm really curious if the year 2 hospitals will pick this up a little bit more. But this is also a cool chance within the model to test something because, as probably most of you know, at the beginning of this calendar year, CMS actually unbundled a number of CPT codes. And so now primary care providers can bill to do remote patient monitoring. And based on the financial analysis that our team did, it is actually a little bit, I just saw the chats are happening. So the SpO2 is being monitored specific for COPD, Grace Ann. There's also an ability to measure a patient's weight as well as their blood pressure remotely. So if a patient has a comorbid, let's say a CHF or something else, often it can make sense to do the blood pressure as well as the weight, but specific to COPD, SpO2 is what we are able to measure at this point. Okay, and then last one, Caitlin. And click one more. So the daily living part is something I'm really excited about. So up there is transportation and mental health. I would say that this has ballooned a lot in the last 6 months though. But I'll go through those two quickly and then touch on some broader aspects. So particularly with the potential year 2 hospitals. So again, we have 5 hospitals that are actively in the model right now, but we also last spring recruited hospitals for the second year of the model, which will start January 1st, 2020. And those hospitals have either completed or are about to complete imminently their transformation plan for submission to CMMI to see about acceptance into the model. And so with the year 2 hospitals, there's been an even bigger push to somehow within the model address transportation. And I think that this is a particularly big issue for COPD patients in terms of getting to your pulmonary rehabilitation classes. The other angle I think that hospitals are considering is, can they offer pulmonary rehabilitation at a time that isn't just normal business hours, so that if a patient has a caregiver or a loved one that could take them after normal business hours, what could that potentially look like? But I think within the model, we would really like to explore opportunities for public-private partnership transportation solutions. And that is something that, yes, I think will benefit the COPD patients, but I think it'll benefit patients more broadly as well. And that's one where I don't think any one hospital, I certainly don't think I have an answer to that on my own. It's an intractable problem that is not unique to Pennsylvania. But I think if we are able to get everybody together, both from the hospital side, you know, important private partners that we have, as well as the government potentially, that we might be able to start to make a little bit of progress. Mental health is a really important component of COPD, particularly in rural. Obviously, screening for depression is very important. But the other piece of this that I think we've started to do in a big way with the year 1 hospitals and the year 2 hospitals, I think are committed to continuing this legacy, is starting to do assessments for high need, high cost patients who are often, you know, their primary diagnosis is often COPD, but doing an assessment of the social determinants of health for which the patient struggles. And this is something that we're really excited about because the China is fantastic. Everybody does it a little bit differently though, and that is based on the whole community. But what we are really trying to get to ground truth on is what are the social determinants of health that the patients who are considered high need, high cost struggle with the most. So I'd like to get to a level of fidelity where we say 50% of you know, COPD patients that go to hospital A are struggling with transportation. To me, that's actionable data and information because the hospital is you know, taking a risk, doing this new model, trying to work within this totally new incentive structure. And I think they then have an opportunity to say, this is the data that we're working with. Our ability to manage these patients effectively is what will help us to stay open as a hospital. And I think that that's a pretty compelling argument that we would like to try to make to a variety of people. So all of the year 1 hospitals are doing this. They've committed to send to me kind of anonymized, rolled up data about which determinants their high need, high cost patients are struggling with. Again, at many hospitals, COPD is the primary diagnosis that makes up a large percentage of those high need, high cost patients. But then with that data, I'm hopeful that we can start to make progress relative to those determinants that patients are struggling with the most. So that's a little bit about what we've been up to in Pennsylvania. I'm happy to answer any other questions, but also respectful of time and knowing that Dr. Doyle comes after me, definitely don't want to shortchange everyone on his case.
That was wonderful. Thank you so, so much. We all appreciate it. Guys, we definitely have time for questions if you guys have any. Everybody is muted, just by the way. And also, Kira, if you don't mind, if we get any questions afterward, do you mind if I forward those to you?
Oh, no, that'd be great, Caitlin. Thanks.
Yeah.
Hey, Kira, this is Chaffee. So, you know, I'm really excited about what you all are doing up there in Pennsylvania and think that it's really interesting and maybe worthy of imitation. So let me ask you, if this succeeds beyond your wildest imagination and it's super effective, what do you think next steps are from there?
So if the model as a whole is wildly successful or the COPD aspect of things?
Let's just say the model. I mean, if it seems like this really works, then how does it get adopted by other places?
Yeah, so, well, the adoption by other places, I think, is maybe a different question. But from my perspective, if this is wildly successful, we are going to see a meaningful difference in health outcomes, access, and quality for folks who live in our rural communities. And moving the needle on those 3 things in particular, particularly population health and access, that is going to take a very long time. So we're testing this model over the course of 6 years. I don't expect that we are going to be able to achieve, to be quite blunt, the type of impact that I think we have in our minds as what success really looks like in even 6 years. So I'd love to see that in 6 years we make tangible progress on those domains, but I don't think that challenges like that, particularly when you're talking about the population health outcomes, are achievable in 6 years. So I guess in my mind, if this was successful in those first 6 years, we would just be able to operate in this fashion. And it wouldn't anymore be a tested model. It would be just the way that we pay for rural healthcare in Pennsylvania. And it would just be adopted as the way that we do business in the Commonwealth. In terms of how this gets rolled out more broadly, CMS has given a soft announcement that they are going to do a national rural health model. That will be formally announced in the fall. I was given my formal talking points on this on Friday, and now I'm trying to recall exactly what they are. But basically, CMS has not finalized the methodology for the national model. They are definitely looking to Pennsylvania to understand both best practices and if there are any unintended negative outcomes. But the methodology hasn't been finalized, though it will be announced, and the particulars about who is eligible, what states it's going to be in, or all states, that'll all come out this fall. So, I don't know that the Pennsylvania model specifically I don't think that will be the model for national, but I think it's definitely going to play a part in informing what the national model looks like. And Graceanne, you had just popped up a question about telemedicine. So I think we had earlier in the year, and to be honest, we've not really kind of done as much with this as I think we thought we may have earlier in the year. But I think a lot of hospitals were looking at doing telemedicine to get consultations with pulmonologists. And one hospital is pursuing that, but is running into a lot of difficulty because they're an independent hospital. So trying to find sort of that right fit for who should provide that service has been difficult for them. But that actually, I thought that was going to end up being a bigger thing with a lot of the hospitals, but it actually hasn't, because I think some of the hospital leadership thought that they needed the ability to consult with a pulmonologist, which is definitely a very legitimate thing, but they need that more for the tough cases. And you don't necessarily need that for every newly diagnosed COPD patient, nor do you have to have a pulmonologist to diagnose someone with COPD. And I think that was a little bit maybe of a misnomer with some of the hospitals earlier in the year. And I think that got cleared up for them via a number of avenues and channels, if that answers your question.
Thank you, Kier. Dr. Sela had a question, I think.
It was more of a statement. I think the transportation issue is really big. I have a huge no-show rate in my clinic, and I'm actually working with my CEO and my clinic manager now to try and figure out what to do, with those patients. In our clinic in particular, they get a phone call 1 week before their appointment. They get a phone call 2 days before their appointment. And when they're at their previous appointment, they get an appointment card with, scheduling with the appointment time and date. And we're still having a significant amount of no-shows. And that's, I think transportation is a huge issue, and trying to be able to get to these people in the community. So I'm interested, if you guys come up with a solution that works and what we could apply here in Preston County.
Yeah, well, one of the things I kind of batted around with a colleague, and I think that this is in West Virginia, but you're going to have to forgive me, the details of this are a little bit fuzzy for me right now, but they have a mobile health van, and this is being piloted, I think, in like southwestern Virginia, or West Virginia, southwest West Virginia. There we go. I had sort of thrown out to my colleague, like, well, I wonder if it would be possible for us to almost have a mobile van like that, but it's like the pulmonary rehabilitation van. And with, at least with this mobile health van, they literally go and park it in like the Walmart parking lot. And they do mostly like preventative health types of activities in it, but they can also use that to then refer patients to a primary care physician that's closest to them. So it's kind of a way of meeting patients where they're at. So that doesn't necessarily help your no-show rate, but I thought that that was kind of a creative idea for how to, you know, if they can't get to you, how do you get to them? And that was something that I at least thought was an interesting concept and potentially worth pursuing. But I can definitely let you guys know if and when we come up with anything.
Awesome. Thank you so much again, Kira. I think a couple more people do have questions, but we're going to move on to the case. And I will forward those to you, and we really appreciate you coming and talking today.
You bet, thanks.
Yeah. So Dr. Doyle, I have all of the phone numbers muted right now, and I'm not sure which one's yours. So if you could unmute yourself. Do you want to discuss the case? I guess I can try unmuting all of them. Let's see.
Okay, I think I'm unmuted now.
Awesome.
Can you hear me?
Yes. Yes, we can.
Okay, great. So the time that I see is 8:37, and I feel like, and Chaffee, if you feel differently, since this is really your case, or Cabin Creek case, speak up. But I think it would be good to go ahead with the questions. I think if we have 15 or even 10 minutes, that's enough on this one, Caitlin. So I'd like to encourage to go ahead and use the other questions. Thanks for your consideration.
Sure. Okay, if anybody else, wants to say their questions, we can start the case at 8:45. That's fine. Gracie Ann did have a comment. Let me see. It's my sense that adjusting the hours for pulmonary rehab to evening or weekend when others are available to bring in the patients would move the needle in attendance. Everybody seems to agree with that.
So let's see. I think that Chaffee and I and Allison are the only, and Caitlin are the only hub members present today. Am I forgetting? Did I miss somebody?
Dr. Stansbury is on now.
Oh, great, great. So I would really like to challenge some of the other hub
Steve
members.
Hoffman also.
Oh, and Dr. Hoffman. Hi, Dr. Hoffman.
Oh, and Dr. Oh, great, great. All right. To comment on what you've heard and how you think that might possibly apply in West Virginia.
Well, we just actually submitted a grant to NIH looking at actually care delivery for sleep apnea in, our local rural population. And, what we do in sleep medicine actually relies a lot on sort of remote monitoring and remote technology. And we do have some of the similar issues. I mean, I still see patients who don't have, Wi-Fi and cell phone service. One of my patients actually drives his CPAP machine into McDonald's every Friday to have coffee with his friends so it can be downloaded on their Wi-Fi and have me look at it. And I think, one of the things that we have that using technology to try and reach these patients is great. And, this remote monitoring is really good, but, really making sure the infrastructure is in place is also really important to be able to reach these folks.
Rob, this is Dan. Something that we often wonder about, and this is your field, is how big a piece of the COPD puzzle, which Kira in their model have named PAU, potentially avoidable utilization. We often worry that failure to diagnose or failure to treat obstructive sleep apnea is a big piece. We have lots of patients, who qualify for oxygen and they get put on 2 liters a minute or 3 liters a minute through the night, but we suspect that what they really have is sleep apnea and they haven't had a full sleep study. So I guess what I'm asking is, what's your sense about what part of the COPD readmissions, ER use in COPD patients is attributable to undiagnosed or untreated or undertreated sleep apnea?
Yeah, I mean, the epi data would certainly suggest that, untreated sleep apnea leads to more exacerbations, and when you treat them, you actually keep them out of the hospital. The big group that looked at that was the Marin group in Spain, actually. But there's been a lot of data out, since that study was done in sort of 2010s, I believe, that have shown that treating sleep apnea is very important. And when you look at sort of the phenotype of COPD now, that very old cachectic person, you just don't see that as much anymore as the morbidly obese. The obesity epidemic's hitting everywhere. But it's hitting West Virginia in particularly hard. So you see a lot of this, what's called overlap syndrome of OSA and COPD. And when you look at their outcomes, just COPD or just OSA versus OSA plus COPD, it's almost like a synergistic effect on how poorly they do when they're not optimally treated. So it's a very important consideration.
So that really sounds like a theme for us to put more attention to now and in the near future. And we know the difficulties getting people to use their CPAP, but I think there are plenty of people who could use and would use if they had it available. I just had a patient at Tug River Health Center who had moved from Ohio. And in Ohio, she had sleep apnea. She was diagnosed. She had a sleep study. She was getting her CPAP. She moved back to West Virginia 6 months ago, and since then has not had CPAP at all, and is having difficulty getting it. And something you said at one of our echoes earlier this year, where we talked about if there's a clinical diagnosis, maybe I'm misquoting you, but if there's a clinical diagnosis of obstructive sleep apnea and good evidence, and especially if there's just been one sleep study, and again, correct me if I'm misquoting you, but we could just start it and put them on reasonable levels instead of holding off because they haven't had a titration study, so forth.
Yeah, you can put people just on auto CPAPs, and I've certainly done that, and just address their sleep apnea. There is some argument back and forth if someone's on supplemental oxygen, at least based on the current recommendations by the American Academy of Sleep Medicine, they should come into the lab for titration because they're at risk for hypoventilation and more complex apnea. But that's not always practical for everybody. I would also say, though, that, when we can bring them to the lab, my feeling is, and we presented some of this data at ATS, when you look sort of globally when they've done studies on, just starting people on CPAP versus doing a formal titration, it's really, the auto CPAP's non-inferior. But what we found in our local rural setting is that, our patients actually do better if they work with a, respiratory therapist and sleep technologist, getting titrated appropriately and making sure the mask fits optimally and all those sort of things.
To me, this sounds like, I'm sorry, but go ahead.
So I was just going to say, the logistics of getting someone to the lab, though, is, very difficult. And, and getting to Allison's point, transportation's a real issue, for people to come in. And, sometimes we run into the part where we'll diagnose someone with sleep apnea in December, and then they can't get out of their house because it's, the road snowed covered until March, and then they don't even remember what they're supposed to be coming to the sleep lab for when they can finally get out. So
it sounds to me like kind of a clinical, a classic clinical translation issue. And that is what the whole WVCTSI effort is. Well, for us, application, that's what it's about. Just getting it to people who need it.
Mm-hmm.
Rob, I have a question. I don't know if you have a workaround to this, but we have patients that get their CPAP, and then based on Medicare, Medicaid guidelines, they've got to show compliance. But I've got patients that, like everybody else is saying, don't have internet, don't have Wi-Fi, aren't willing to drive their CPAP to McDonald's, and then they end up having their equipment taken away because they can't demonstrate that they've been wearing it. I see them in clinic, and they tell me they've been wearing it and that they feel better. Do you have any thoughts or suggestions on that?
Yeah, the only thing I can say that sometimes is helpful, you got to remember to ask, but most of the CPAPs they send out now just have a modem that, uploads to this cloud-based thing that you log into and track their compliance. So they don't always get the cards anymore. Now, all these machines still have a port for a data card. So you can request that they get a data card, and then they can mail it in for download. But that's, and then the other thing is, and it's tough, but if they're coming in for an appointment, there's a little buttonology to it, but you can pull the raw data off of their machine, if it's not uploading to the server.
Thank you.
I just want to check. Okay, we're going to do the case in a minute, but I just want to check. And Chaffee, I'm going to ask you to help. But I just want to check if Carl or Krista or Kim, Steve Hoffman have any other comments about the Pennsylvania model and its potential.
I think all these models are interesting. I was in a meeting in DC last week or 2 weeks ago about a lot of these kind of models for different things. And the problem is, the speaker's right. 6 years is really not even enough time to find out if it works. And there's a lot of different versions of this model out there. It'll be very interesting to see if and how any of it really operates and functions. And I actually, on a personal level, I think part of the problem is these are 6 to 8 year projects, and then halfway through, somebody, CEO changes, somebody changes, whatever changes, and we start over. So I think part of the key to this is going to be stick to itness for one single plan.
Definitely.
Okay. Well, what I would like to propose is that we spend the little time we have left, and Caitlin, call time for us, and I'm actually supposed to go into another meeting at 9 here at the Fayette County Board of Education about Juul and e-cigarette prevention. But Chaffee, I felt like when Dr. Asbury was talking about, you know, obesity and obstructive sleep apnea, that was kind of a cue for you to say something about how you're using what we've learned from pulmonary rehab to address that. And if you would do that and then try to segue into the case, that if you can do all that, that would be great. And I'll help with the case if you need it.
You don't expect much.
I know that's expecting a lot, but I know you can do it.
It is. So I think that one thing that we're seeing is that there are people that need pulmonary rehab services that don't meet classic spirometric guidelines for reimbursement by CMS specifically. So I feel a little put on the spot here, but I think that we've been looking for ways to expand that model to care for some of our other patient populations. We're cognizant that we have a very, very nice space, thanks to Grace Ann and Benedum and others. And we want as many people in the community to be able to use that as possible. And so we are looking at adding into the panel of services we offer something called therapeutic exercise and education. We have a diabetic class, for instance, here at our site. However, we tell them to exercise and there's not a way for them to exercise. So, you know, a way to help them structure that. We also have a pain group. We tell them to exercise. There's not a way for them to exercise. So we're looking at ways that they can use the equipment when it's not in use by people that do qualify for pulmonary rehab with their spirometries. That said, we have a patient who has a restrictive lung disease, about 80. His primary problems candidly just are not his breathing. He's diabetic. He has real balance issues. And so we have been working with him and have seen some improvement probably in his dyspnea, but much more improvement in his A1C. And one of the take-homes from our cardiac rehab workshop in La Crosse for me was working on balance. That's really probably the biggest threat to our elderly patients. And we've seen just marked improvement in his balance. So I don't know what else you want me to say about that, Dr. Doyle, but feel free to hop in with whatever you think I've missed.
Well, I think you just mentioned the A1C improvement in relation to our patient who's the case today, right?
That's correct.
So would you mind, do you have the case in front of you?
It's up on the screen.
Okay, would you mind, is Krista there?
She's not.
Okay, so would you mind just taking us through the case?
Okay, so it's an 80-year-old white male with various heart, lung, neurologic, and diabetic comorbidities in pulmonary rehab. Let's see, he had DOL testing, chest ray was negative for black lung, exercise, ABGs, PO2 was 77 at rest, 76 with exercise. He had a really bad episode where he was sick the day that he was to graduate and missed something like 3 weeks. So we're letting him do a couple sessions just to sort of build back his strength. Let's see. Respiratory diagnosis, restriction, not obstruction, coronary artery disease, diabetes, has been on insulin, but his blood glucose is running actually low. I think it was 87 the last time he was here. And so I think we're looking, probably his primary care provider is looking at easing off some of those medicines. Leg weakness and abnormal gait, spinal stenosis, left knee replacement. Anyway, very limited smoking history, smoked for 6 years, quit 62 years ago. Is that right? No, I'm sorry. 52 years ago. Okay, you can keep scrolling, Caitlin. Yeah, so FVC with a percent predicted of 65, FEV1, or excuse me, FVC 60, FEV1 65%, the ratio is 78%. What else would you like me to say, Dr. Doyle?
Well, actually, I went through his chart last night. So actually, he graduated last week. And so his 6-minute walk test improved from his original, see, I think it says 250 there, I think 240. It improved to 345. As Kathy said, he had other benefits, though, from this activity, especially with his diabetes. I looked, he does not have COPD, so really the GOLD guidelines don't apply directly to him. But I do think that method that GOLD uses to categorize patients, their grade and their group, is still useful as a rule of thumb for somebody like this. And so I saw him, I think, as being, based on his MMRC of 2 at the start, which rose to 3 at the end, I saw him as kind of in a group B, if we be allowed to apply that to somebody with restrictive disease. And our goal is to prevent exacerbations regardless of what the person's chronic disease is, and prevent PAU regardless of what their disease or sets of disease are. And I guess given that this person certainly doesn't have severe COPD, and given his O2 sats, and I think his exercise blood gas studies, and it's kind of borderline TLC and DLCO. I think they were both in the range of about 65. The main clinical question I had about him, and I'm going to probably jump off because I have to go into this other meeting. His big thing was we were really worried that or at least I was, that he was at risk walking on a treadmill. But I think he was able to walk on a treadmill, wasn't he, Chaffee?
He was, and did every session from fairly early on.
Yeah, but when you see him walking around with his cane, with his left total knee replacement, with being kind of weak, and with his lumbar spine stenosis surgery, it's a little scary, and he seems like somebody at high risk for falls. So my question for Allison and for us was, whether his musculoskeletal imbalance problems were a relative contraindication to pulmonary rehab or cardiac rehab or treadmill exercise. We decided not, but I'm curious how other people would deal when we're providing medical clearance to go ahead and do therapeutic education and exercise, cardiac rehab, pulmonary rehab, how we think that through and weigh the risks. Weigh the risks of doing it and the risks of not doing it. And with that, I'm going to say goodbye.
Thank you, Dr. Doyle.
So I think, and Chaffee, you're aware of the different things that Chris is doing in our rehab program, but pulmonary rehab doesn't always mean getting on the treadmill. There's other options that we have, such as the arm ergometer or the new step, where patients that may be a little more musculoskeletally unbalanced can still participate. And in addition to that, Chris, our respiratory therapist, is also doing some really innovative things where he's having patients carry a laundry basket and reach down to pick up a sandbag and then carry that down the hall to pick up another sandbag. And he's also, we were discussing just last week, he's having patients unpack cans from a grocery bag and put them up in the shelves. And we've got a little kitchenette that he uses, and unpack them and pull them out of the shelves and reach up and down, and everyday activities that patients are going to be doing. So I think as far as safety on the treadmill, obviously it's something we need to pay attention to, but there are other options that would not preclude people from participating in pulmonary rehab.
Absolutely. And there are people that we have that, you know, don't use the treadmill at all. This particular gentleman, because he could keep his hands on it, we felt like was steady enough. I think we held the treadmill the first few sessions and tried it with several of us, and he actually, I think, is better on the treadmill than he is on level ground, just because he can hang on with both hands. He looks scary, but he actually hasn't fallen very much, and we have worked a lot with him on balance. So,
Great.
thanks.
All right, thank you, Chaffee, for doing the case. We really appreciate it. Everybody, it is 9 o'clock, just after 9 o'clock, so we're going to call it here. But if you guys have any further questions, please feel free to email those and we'll forward them appropriately. And our next session is on the 19th. I'll make sure to send those reminders. Thank you all, and thank you, Kira, again.
Happy Monday. Thanks, Kira.
Thanks, guys. Take care. Bye.